Introduction: Psoriasis is a chronic, inflammatory skin disease that varies in appearance, affected areas, progression, age of onset, duration, and triggers. It is an immune-mediated condition caused by abnormal activation of dendritic cells and T cells, which release inflammatory cytokines, notably IL-17, IL-23, and TNF-alpha. These cytokines drive changes in psoriasis plaques, like epidermal overgrowth, increased blood vessel formation, and inflammatory infiltration. Psoriasis is associated with comorbidities, including metabolic syndrome and arthritis. Historically, psoriasis was described by Hippocrates, while Galen used the term psoriasis vulgaris to refer to itchy skin conditions. The term psoriasis originates from the Greek word psora, meaning itching. In 1809, Robert William categorized psoriasis within erythematous scaly diseases. In 1841, Ferdinand von Hebra and Moritz Kaposi defined its clinical and pathological features, differentiating it from leprosy. Epidemiology: Psoriasis affects 2 to 3% of people in Europe and the United States, but only 0.4 to 0.7% in Africans, African Americans, and Asians. The disease can begin at any age, from infancy to the 80s, with two peak onset periods, 16 to 22 years and 57 to 62 years. Early onset, before age 15, is linked to more severe disease, greater affected area, and harder treatment response. Early onset also correlates with a higher likelihood of family history. Prevalence appears to rise with age, possibly due to the bimodal onset pattern and an increase in late-onset cases. Psoriasis affects men and women equally, but men may experience earlier and more severe cases. Etiopathogenesis: Psoriasis has been recognized for over 200 years, but many epidemiological aspects are still uncertain. It is a multifactorial disease with an unclear etiology. Genetic predisposition plays a role, along with environmental triggers like stress, smoking, obesity, alcohol consumption, viral or bacterial infections, vitamin D deficiency, certain medications. Genetics: Most genetic studies focus on plaque psoriasis, indicating a high heritability. 9 psoriasis-related genetic loci, SORS1-9, have been identified. SORS1 is the most critical locus, responsible for 35 to 50% of heritability, located on chromosome 6p21 within the major histocompatibility complex. The HLA-CW6 allele, a key risk factor, is present in 30% of psoriasis patients, versus 10 to 15% of the general population. The homozygous HLA-CW6 carriers have 2.5 times the risk of developing psoriasis compared to heterozygous carriers. HLA-CW6 is associated with early onset, extensive plaques, the Koebner phenomenon, and frequent streptococcal pharyngotonsillitis as a trigger. Some rare cases of pustular psoriasis result from mutations in IL-36RN, which encodes an anti-inflammatory protein. CARD14 mutations are linked to generalized pustular psoriasis, especially in cases with concurrent plaque psoriasis. Environmental factors: Smoking increases psoriasis risk, especially with childhood exposure and heavy smoking history. Obesity, linked to higher psoriasis risk, with a 9% increase per BMI point. But psoriasis does not increase obesity risk. Alcohol consumption contributes to disease onset and flare-ups. Infections: Bacterial infections, especially streptococcal, are common triggers. HIV infection leads to more severe cases. Psychological stress often triggers psoriasis flare-ups a few weeks after stress. Mechanical trauma, Koebner phenomenon trauma, sunburn, or drug/viral reactions can lead to lesions, especially in HLA-CW6 positive patients. Drugs: lithium, beta blockers, interferon, antimalarials, and rapid corticosteroid withdrawal can worsen psoriasis. Endocrinological factors: hypocalcemia can trigger pustular psoriasis. Pregnancy may improve or worsen the condition. Climate: warm weather and sun generally improve psoriasis, while cold weather worsens it. High humidity may worsen palmoplantar pustulosis in Japanese patients. Pathogenetic mechanisms: key pathological changes in psoriasis include epidermal hyperproliferation, accelerated keratinocyte movement from basal layer to epidermis, 4 to 5 days in psoriasis versus 30 days in healthy skin. Inflammatory infiltration, infiltrative inflammatory cells in dermis and epidermis, increased angiogenesis, greater blood vessel formation in affected skin. The IL-23/IL-17 immune axis is central to psoriasis, with myeloid dendritic cells, MDCs, releasing IL-23 and activating T helper cells, Th17, Th22, and other immune cells to produce IL-17, driving inflammation. Additional pro-inflammatory cytokines, IL-22, IL-17F, IL-21, TNF-alpha, NO, IL-20, from T cells, mast cells, and dendritic cells contribute to psoriasis plaque formation. Resident memory T cells, TRM, play a role in psoriasis persistence. TRM cells, particularly CD8, CD103, CD69 lymphocytes, are stable in skin tissues and act as sensors for pathogens. TRM cells are elevated in both affected and clinically normal skin of psoriasis patients, correlating with disease duration and severity, PASI score. These cells express IL-23 receptors, can produce inflammatory mediators long-term, and are implicated in lesion recurrence. Clinical forms: plaque psoriasis vulgaris, most common type, guttate psoriasis, often appears as small, dot-like lesions. Erythrodermic psoriasis involves widespread redness and shedding. Pustular variants, generalized pustular psoriasis. Severe, with widespread pustules. Hallopose acrodermatitis continua, affects fingertips. Palmoplantar pustulosis, involves the palms and soles. Nail involvement, psoriasis can affect nails, causing pitting, discoloration, and crumbling. Plaque psoriasis vulgaris, clinical pattern. Plaque psoriasis is the most common form, seen in 80 to 90% of adults, characterized by well-defined, erythematous scaly plaques, sometimes with a lighter worn-off ring halo. Lesion characteristics: sizes vary from millimeters to large areas. Small lesions may merge into large plaques with unique shapes or annular, ring-like, morphology. Lesion edges are typically circular, oval, or polycyclic due to smaller lesions merging. Central clearing of plaques can leave post-inflammatory hyperpigmentation or hypopigmentation. Distribution and affected areas: lesions are symmetrically distributed, commonly on the scalp, elbows, knees, sacral region, and navel. Scalp involvement can extend beyond the hairline, sometimes causing hair loss. Telogen effluvium. Palmoplantar involvement may lead to painful hyperkeratosis, affecting daily activities. 4. Oral mucosa involvement. Oral lesions are not uncommon. Geographic tongue and fissured tongue are most common. Some patients may experience periodontitis or stomatitis areata migrans. 5. Disease course: chronic with plaques that can persist for months or years, but some patients have complete remission periods. Unstable psoriasis, flares with more inflammatory, erythematous, painful, or pruritic lesions that enlarge or spread quickly. Triggers include steroid withdrawal, irritant treatments, acute infections, and hypocalcemia. Elevated serum IL-17 and IL-1 receptor antagonist are observed in flare-ups. 6. Complications and considerations: some flares may regress to stable forms, while others progress to erythroderma or pustular psoriasis. Recurrent severe flares may suggest an underlying HIV infection. Flexural, inverted, psoriasis. Flexural psoriasis characteristics: lesions are well-defined, shiny plaques with minimal scaling. Common sites: axillae, groin, intergluteal, and submammary folds. Fissures may form, particularly in the intergluteal fold. Occurrence and manifestation: flexural involvement can occur with plaque psoriasis or as the sole manifestation, may result from Koebner phenomenon due to infections or inflammation in folds. Diaper area involvement is a common presentation in childhood. Genital involvement, classified as a type of flexural skin, affected in inverted or, less frequently, plaque psoriasis. Men, most common site is the glans, with erythematous plaques and variable scaling. Women, usually presents on the labia majora as a thin, erythematous, asymmetrical plaque without scaling, often causing intense itching. Guttate psoriasis. Guttate psoriasis, more common in individuals under 30 years of age, can be the first manifestation of psoriasis, especially in young people, or an acute flare in those with plaque psoriasis vulgaris. Often appears 2 to 3 weeks after a group of streptococcal infection, usually respiratory, but can also be perianal dermatitis. Clinical features: numerous small erythematous, scaly plaques, 0.5 to 1.5 centimeters in size, commonly found on the trunk and proximal limbs, sparing palms and soles, characterized by the Koebner phenomenon. Lesions appear at sites of trauma. Course and prognosis: lesions usually resolve within 3 months. Some patients may experience intermittent recurrences, while others may develop plaque psoriasis vulgaris. Erythrodermic psoriasis, psoriatic erythroderma, rare form of psoriasis, affecting 1 to 2% of patients. Psoriasis is the underlying cause in 25% of erythroderma cases. Clinical features: generalized erythema covering more than 90% of the body surface, can be chronic, gradual extension of plaque psoriasis, or acute, part of unstable psoriasis. The chronic form, patient generally maintains good health. Psoriasis features remain present, with areas of healthy skin still visible. Acute form, often triggered by systemic disease, alcohol use, antimalarial drugs, ultraviolet radiation, irritating topical treatments, or withdrawal from systemic steroids, cyclosporin, or methotrexate. Symptoms include poor general condition, fever, intense itching, and complete loss of characteristic psoriasis features. May overlap with generalized pustular psoriasis. Serious complications associated with temperature fluctuations, protein loss, electrolyte imbalances, dehydration, kidney and heart failure. Pustular variants: pustular psoriasis, characterized by the presence of neutrophils in the epidermis, a histologic feature common to all forms of psoriasis. The term pustular psoriasis refers to forms with visible macroscopic pustules. Key differences: pustular psoriasis and plaque psoriasis are phenotypically distinct and respond differently to treatments. Evidence suggests they are genetically different as well. Classification: the European Consensus on the Phenotype of Pustular Psoriasis has provided a phenotypic classification for different forms of pustular psoriasis. Generalized pustular psoriasis, generalized pustular psoriasis, GPP, characterized by sterile, macroscopic pustules on non-acral skin, excluding pustules confined to psoriasis vulgaris plaques. May or may not be associated with plaque psoriasis lesions. Can present as flares or persistent disease. Prevalence varies by geographic region, more common in women than men. Impetigo herpetiformis, a rare condition where pustular psoriasis flares during pregnancy, usually in the 3rd trimester, can also be triggered by menstruation or hormonal therapies, estrogen and progestogen. Often seen in patients with a personal or family history of psoriasis. Severity of GPP. Severity is determined by lesion extent and the presence of fever and analytical abnormalities, e.g., leukocytosis, elevated acute phase reactants, hypocalcemia, hypoalbuminemia. Severe cases can be life-threatening, with complications like sepsis and multi-organ failure. Acrodermatitis continua of Halipo. Acrodermatitis continua, a rare manifestation of psoriasis, characterized by sterile, macroscopic pustules on the distal portions of the fingers, sometimes affecting toes. Typically starts on the pulp of 1 or 2 fingers and can coalesce into large pustular lakes. As the disease progresses, the affected area becomes bright erythema, or develops into a keratotic, fissured, and crusted surface. Nail involvement. Pustulation affects the nail bed and matrix, often leading to nail plate loss or severe onychodystrophy. In chronic cases, complete destruction of the nail bed and even osteolysis of the distal phalanx may occur. Other features may be accompanied by a migratory ring on the tongue. Not usually associated with plaque psoriasis. Palmoplantar pustulosis. Palmoplantar pustulosis, relationship with psoriasis vulgaris is controversial, occurs together in 25% of patients with plaque psoriasis, but usually isolated and not associated with genetic changes of plaque psoriasis. Primarily affects adults aged 30 to 50 years, more common in women, 80 to 90%. More than 90% of patients are current or former smokers. Clinical features: characterized by erythematous scaly plaques with sterile pustules that evolve from yellowish to brownish in 8 to 10 days. Pustules range from 1 mm to 1 cm. Present at various stages of development, lesions are symmetrical, especially on the feet, and most prominent on the thenar and hypothenar eminences, soles, and lateral surfaces of the feet. Associated condition: most common skin manifestation of Sappho syndrome, synovitis, acne, pustulosis, hyperostosis, and osteitis. Nail involvement affects 15 to 50% of psoriasis patients, and 90% of patients with psoriatic arthritis, may be the only manifestation in 6% of total psoriasis cases, correlated with more severe disease, earlier onset, and higher risk of developing psoriatic arthritis, more common in men, can cause pain and significantly affect functionality and quality of life. Nail changes reflect involvement of different parts of the nail, including the nail matrix and nail bed. Nail matrix involvement: pitting, punctate depressions in the nail plate due to parakeratosis in the matrix, most common. Leukonychia, red spots on lunula, and nail dystrophy. Nail bed involvement: splinter hemorrhages, onycholysis, oil or salmon spots, and subungual hyperkeratosis. 2. Specific lesions: pitting lesions, most common nail disorder, deeper in psoriasis than in other conditions like eczema or alopecia areata. Oil spot onycholysis, yellowish lesions, very specific to psoriatic nail involvement. 3. Nail location: hands are more commonly affected, especially the fourth finger. Feet are often affected with nail hyperkeratosis and onycholysis, more common in the toes. Histology: initial changes in psoriasis plaques, vasodilation and edema of the papillary dermis, lymphocytic infiltration, progression of lesions, compact hyperkeratosis and disappearance of the granular layer. Epidermal hyperplasia, established plaques, psoriasiform hyperplasia with elongated dermal papillae, suprapapillary thinning, confluent parakeratosis over a diminished granular layer, interepidermal neutrophils. Histologic features: edematous papillary dermis with dilated, tortuous vessels, mixed inflammatory infiltrate, mainly lymphocytes, with neutrophils and macrophages. Pathognomonic features: Kogoj spongiform pustule, neutrophil accumulation in a spongiform pustule, Monroe microabscess, neutrophil remnants in the stratum corneum, surrounded by parakeratosis, lesion heterogeneity. Active and nonspecific chronic areas coexist in the same plaque. Peripheral zone of the plaque is usually more active. In pustular psoriasis, characteristic macropustules with central cavitation. Epidermal and dermal findings are similar to psoriasis vulgaris. Diagnosis: diagnosis of psoriasis, primarily clinical. Typical psoriasis lesions are usually sufficient for diagnosis. Brock methodical scraping, a diagnostic maneuver to distinguish psoriasis from other skin diseases. Involves scraping an untreated plaque with a metal spoon. Wax candle sign, whitish scales with characteristic consistency. Duncan-Buckley membrane, shiny membrane appears. Auspitz hemorrhagic dew, moist surface with hemorrhagic dots, indicating dilated dermal vessels and thinning epidermis. This method is not applicable for pustular or inverted psoriasis and may also appear in seborrheic dermatitis. Dermoscopy can assist in diagnosis. Skin lesions show red dots, glomerular vessels, and a reddish/pink color with white or yellowish scales. Scalp involvement, red dots and dilated, tortuous vessels. Nail psoriasis. Typical signs include onycholysis, oil spots, and splinter hemorrhages. Histological examination: in doubtful cases, a histological examination may be used to confirm the diagnosis. Differential diagnosis: plaque psoriasis, lichen simplex chronicus, nummular eczema, lichen planus, pityriasis rubropilaris, Bowen's disease, cutaneous lupus, mycosis fungoides, acrodermatitis continua, acute bacterial or mycotic paronychia, early stage of acrodermatitis, contact dermatitis, pustulosis palmoplantar, palmar or plantar dyshydrotic eczema, generalized pustular psoriasis, acute exanthematous pustulosis, subcorneal pustular dermatosis, psoriasis palmoplantar, chronic eczema, psoriasis gutata, Pityriasis rosita, lichen planus, chronic lichenoid pityriasis, secondary syphilis, parapsoriasis, erythroderma, drug reaction, atopic dermatitis, Sézary syndrome. Pityriasis rubropilaris, reverse psoriasis, seborrheic dermatitis, candidiasis intertrigo, tinea cruris, contact dermatitis, Langerhans cell histiocytosis, null psoriasis, onychomycosis, traumatic onychodystrophy. Face and a scalp involvement, seborrheic dermatitis, genital involvement, keratoerythroplasia, plasma cell balanitis. Psoriatic arthropathy, chronic arthropathy first recognized in 1964, part of seronegative spondyloarthropathies, affects 0.3 to 1% of the general population and 5 to 30% of psoriasis patients. Peak incidence between 20 to 40 years, with equal gender distribution. In children, it begins around 9 to 10 years, more common in girls. Genetics and pathogenesis. Genetic basis with a 6.6% prevalence in first-degree relatives, associated with polymorphisms in HLA-B13, B57, B39, CW6, CW7, and TNF-alpha, IL-12, IL-23. Receptor genes. HLA-CW6 shows a strong link with both psoriasis and PSA, environmental factors and infections, e.g., molecular similarity between streptococcal antigens and epidermal autoantigens, may trigger the inflammatory response. Clinical forms and classification, traditionally classified into 5 clinical forms: asymmetric oligoarthritis, distal interphalangeal joint arthritis, polyarticular arthritis, mutilating arthritis, and axial involvement. Now classified into 2 subgroups based on response to treatment and association with HLA, axial disease and peripheral disease, which can occur together or separately. Axial involvement affects 20 to 40% of patients, more common in men, linked to HLA-B27, characterized by low back pain, morning stiffness, and alternating buttock pain. Inflammation typically affects the sacroiliac joints with alternating involvement. Peripheral arthritis affects joints such as hands, knees, ankles, and feet, can be polyarticular, oligoarticular, or monoarticular. Interphalangeal joint involvement shows a linear pattern across finger joints, erythema, or purpuric coloration often present over affected joints. Characteristic findings of PSA, enthesitis, inflammation at tendon/ligament insertion sites, commonly at Achilles tendon, rib cage, sacroiliac joint. And others, dactylitis, inflammation of a finger or toe, sausage finger, due to synovitis, tenosynovitis, and enthesitis. Seen in 16 to 48% of patients and associated with poor prognosis. Radiological findings in psoriatic arthropathy, marginal erosions with adjacent bone proliferation, decreased joint space, and periostitis. In advanced cases, complete joint destruction with osteolysis of terminal phalanges, penicillin cup appearance. Prognostic factors: polyarticular onset, dactylitis, female sex, elevated acute phase reactants, and baseline radiographic damage are linked to higher risk of radiographic progression. Timing of joint involvement. Skin lesions typically appear years before joint involvement, 80% of patients. In 10 to 15% of cases, joint involvement appears earlier. In 5 to 10%, both skin and joint disease debut simultaneously. Correlation between psoriasis and psoriatic arthropathy. The relationship between psoriasis severity and psoriatic arthropathy is not clearly defined. Psoriatic arthropathy seems more common in patients with erythrodermic or pustular psoriasis forms. Clinical predictors of psoriatic arthropathy: scalp involvement, intergluteal or perianal lesions, lesions in more than 3 locations, and nail involvement are predictors of psoriatic arthropathy. Role of nail involvement. Nail involvement is linked to joint damage and may indicate joint disease activity. Extent and severity of skin and joint involvement correlate with nail lesion severity, particularly in distal interphalangeal joint involvement. Scales and classification of severity. Severity of psoriasis varies greatly between patients and over time. No validated biomarkers of activity. Clinical scales are necessary for evaluating disease severity in practice and research. No globally accepted scale for severity. Common scales used: PASI, Psoriasis Area and Severity Index, ranges from 0, no psoriasis, to 72, very severe psoriasis. Evaluates body surface area and severity of erythema, infiltration, and scaling, PASI greater than 10. Indicates moderate severe psoriasis. Drawbacks: non-proportional scale, low sensitivity in mild psoriasis, only applicable to plaque psoriasis, high inter-observer variability, most widely used despite limitations. Body surface area. BSA, estimates affected area, with the patient's palm accounting for 1% of body surface. Physician's global assessment, PGA, subjective assessment commonly used by physicians in clinical practice. Nail Psoriasis Severity Index, NAPSI, evaluates nail involvement based on abnormalities in the nail matrix and nail bed. Scores range from 0 to 80. Dermatology Life Quality Index, DLQI, questionnaire used to assess quality of life, validated for clinical trials and routine practice. Other quality of life questionnaires, Skindex 17, Short Form 36, SF 36, EuroQOL 5D, EQ 5D. Moderate correlation with psoriasis severity scales. Moderate severe psoriasis definition, Spain. Criteria: PASI greater than 10, BSA greater than 10, or DLQI greater than 10, requires systemic treatment at some point, including phototherapy, systemic or biological treatment. Erythrodermic, generalized pustular psoriasis, or localized pustular psoriasis with limitations. Psoriasis affecting exposed areas, e.g., face, palms, soles, genitals, or recalcitrant plaques with functional/psychosocial impact. Psoriasis associated with psoriatic arthritis. Principles of care: provide individualized support and information for people with psoriasis, as well as their families or carers. Use varied formats to ensure clear understanding of diagnosis and available treatment options. Lifestyle factors that may affect their condition. Timing and methods for treating psoriasis. Safe and effective use of prescribed treatments, e.g., applying topical treatments, monitoring for side effects. When and how to seek additional general or specialist care. Strategies for managing the physical, psychological, and social impacts of psoriasis. Develop a treatment strategy aligned with the person's health goals to minimize the impact of psoriasis. Using assessment tools to track goal achievement. Consider the person's age, circumstances, disease type, severity, psoriatic arthritis, other health conditions, and treatment history. Explain treatment risks and benefits to the person and their family or carers if applicable, using absolute risk and natural frequency where possible. Emphasize the importance of adhering to treatment for best outcomes. Record a static physician's global assessment, categorizing disease as clear, nearly clear, mild, moderate, severe, or very severe. Document the patient's assessment of disease severity, also using a static patient's global assessment. Note the body surface area affected by psoriasis. Identify any nail involvement or psoriasis in high impact and challenging areas, e.g., face, scalp, palms, soles, flexures, genitals. Check for systemic symptoms like fever or malaise, especially in unstable psoriasis forms, e.g., erythroderma or generalized pustular psoriasis. In specialist settings, use a validated severity tool, such as the Psoriasis Area and Severity Index, PASI. PASI scoring involves selecting a representative area for each body region and assessing redness, thickness, and scaling, rated from none, 0, to very severe, 4. Assess the impact of any type of psoriasis on physical, psychological, and social well-being. Assessment and referral for psoriatic arthritis. Identification of comorbidities. Topical therapy. First-line treatment for psoriasis should be topical therapy. Offer phototherapy or systemic therapy. Second or third-line options when psoriasis is extensive, e.g., affects more than 10% of body surface area, or at least moderate on the static physician's global assessment. Topical therapy is ineffective, such as in cases of nail involvement. Consider patient needs. Tailor topical treatments to patient preference, cosmetic acceptability, ease of application, and Specific treatment area, formulation preferences, use creams, lotions, or gels for widespread psoriasis. Use ointments for areas with thick scale. Use lotions, solutions, or gels for the scalp or hair-bearing areas. Limitations of topical therapy. Recognize that topical treatment alone may not be sufficient for extensive or moderate psoriasis. Support for special needs. For patients with physical, cognitive, or visual impairments, provide advice and practical support based on individual needs. Review timeline. Adults, arrange a review at 4 weeks after starting new topical treatment. Children, review at 2 weeks. During review, assess treatment response, reinforce adherence, and the need for a 4-week break between courses of potent corticosteroids. Topical treatment of psoriasis affecting the trunk and limbs. Initial treatment for adults. Offer a potent corticosteroid applied once daily and vitamin D or a vitamin D analog applied once daily, one in the morning, the other in the evening, for up to 4 weeks. If initial treatment is ineffective, up to 8 weeks, switch to vitamin D or a vitamin D analog alone applied twice daily. If vitamin D or analog alone is ineffective, 8 to 12 weeks, offer either a potent corticosteroid twice daily for up to 4 weeks or a coal tar preparation once or twice daily. For adherence improvement, if a twice daily potent corticosteroid or coal tar preparation isn't suitable, offer a combined product of calcipotriol monohydrate and betamethasone dipropionate once daily for up to 4 weeks. Use of very potent corticosteroids, reserved for specialist settings, under careful supervision, and only when other treatments have failed. Limit use to a maximum of 4 weeks. Alternative for treatment-resistant psoriasis. Consider short-contact dithronol with support for self-use or ensure it's administered in a specialist setting. Treatment options for children and young people. For trunk or limb psoriasis, calcipotriol once daily, for children over 6 years. A potent corticosteroid once daily, for children over 1 year. Topical treatment of psoriasis affecting the scalp. Offer a potent corticosteroid applied once daily for up to 4 weeks. Educate patients and families/carers on proper application techniques for corticosteroids. If initial treatment is ineffective after 4 weeks, consider using a different corticosteroid formulation, e.g., shampoo or mousse. Add topical agents to remove adherent scales, e.g., salicylic acid, emollients, or oils, before applying the corticosteroid. If treatment remains unsatisfactory after an additional 4 weeks, offer either a combined product containing calcipotriol monohydrate and betamethasone dipropionate applied once daily for up to 4 weeks, or vitamin D or a vitamin D analog once daily, for those unable to use steroids with mild to moderate scalp psoriasis. If 8 weeks of continuous treatment does not achieve desired control, offer a very potent corticosteroid applied up to twice daily for 2 weeks, adults only, or coal tar once or twice daily, or referral to a specialist for further treatment support and options. Consider topical vitamin D or analog alone for individuals intolerant to corticosteroids or with mild to moderate scalp psoriasis. Note: avoid offering coal tar-based shampoos alone for severe scalp psoriasis. Topical treatment of psoriasis affecting the face, flexures and genitals. Initial treatment for psoriasis on sensitive areas, face, flexures, genitals. Offer a mild or moderate potency corticosteroid applied once or twice daily for up to 2 weeks. In children and young people, adjust duration as needed. Risk awareness and usage guidelines. Recognize that these areas are more prone to steroid-induced atrophy. Use corticosteroids only for short-term treatment, 1 to 2 weeks per month. Explain the risks of atrophy to patients and their families/carers, and advise on minimizing these risks. Alternative treatment if corticosteroids are ineffective or unsustainable for adults. If moderate potency corticosteroids do not control symptoms or continuous use is needed with risk of side effects. Offer a calcineurin inhibitor applied twice daily for up to 4 weeks. Initiation of calcineurin inhibitors should be done by psoriasis treatment specialists. Avoid high-potency corticosteroids. Do not use potent or very potent corticosteroids on the face, flexures, or genitals. Consideration for topical agents when prescribing. Take into account potential irritation at facial, flexural, and genital sites. inform patients and families/carers about irritation risks and ways to reduce them. Phototherapy, broad or narrowband UVB light and PUVA, offer narrowband UVB for psoriasis. Use narrowband UVB phototherapy for plaque or guttate pattern psoriasis unresponsive to topical treatments. Treatment can be given 2 to 3 times weekly. A faster response may be achieved with 3 sessions per week. Consider alternative treatments if narrowband UVB is unsatisfactory. Switch treatment if UVB therapy is ineffective, poorly tolerated, or if there's rapid relapse, over 50% return of symptoms within 3 months. Use alternatives if accessing treatment is difficult, e.g., due to travel issues or immobility, or if the person has a high skin cancer risk. Consider PUVA for specific cases. Use psoralen, oral or topical, with UVA, PUVA, for treating palmoplantar pustulosis. For PUVA, discuss the skin cancer risks, especially with previous use of cyclosporin or more than 150 PUVA sessions. Topical adjunctive therapy with phototherapy. Add topical treatments for resistant plaques or hard-to-treat sites during broadband or narrowband UVB therapy, especially if systemic drugs are unsuitable. Phototherapy use guidelines. Avoid routine maintenance phototherapy, narrowband UVB. Broadband UVB, or PUVA. Ensure phototherapy equipment meets safety standards and is regularly checked. Training and competence for healthcare professionals. Phototherapy should be administered by trained and competent professionals who follow clinical governance frameworks for safety and adherence to treatment protocols. Risk of skin cancer and how to minimize risk. Avoid PUVA in high skin cancer risk patients. Do not use PUVA for psoriasis patients with a genetic predisposition to skin cancer, e.g., xeroderma pigmentosum, familial melanoma. Avoid PUVA for patients with a personal history of skin cancer, those with over 150 prior PUVA treatments, or for children. Caution with PUVA use. Use PUVA cautiously or consider alternatives for patients at risk for skin cancer, those with lighter skin types. Fitzpatrick types 1 or 2, individuals likely to need cyclosporin or long-term methotrexate, and young people. Skin cancer surveillance and record keeping. Offer lifetime skin cancer monitoring to patients who have received over 150 PUVA treatments or have developed skin cancer. Maintain a permanent record of each patient's cumulative UV exposure, e.g., in a national record system. Systemic therapy. Systemic therapy responsibility. Systemic therapy should be managed in specialist settings, with certain aspects of supervision delegated to non-specialist settings if formalized. Tailoring systemic treatment. Consider individual needs when selecting systemic therapy, factoring in age, disease phenotype, and previous treatments, disease severity and impact, presence of psoriatic arthritis. Consult rheumatologist. Conception plans and comorbidities. The patient's preferences. Understanding risks and benefits. Be aware of the benefits, contraindications, and adverse effects of systemic treatments. Discuss treatment risks and benefits with patients and their families, using absolute risks and natural frequencies where possible. Reviewing response to systemic therapy. Assess treatment effectiveness by comparing disease severity, e.g., PASI scores. Evaluate control of psoriatic arthritis, disease impact, and treatment benefits versus risks. Consider the patients and their families' views. Monitoring and support. Monitor patients on systemic treatment as per national/local guidelines, taking action on any lab abnormalities or adverse events. Offer adjunctive topical therapies to optimize systemic treatment. Outcomes. Long-term safety. Encourage participation in long-term safety registries, e.g., British Association of Dermatologists Biologic Interventions Register, for patients starting non-biological or biological systemic treatments. Systemic non-biological therapy. Criteria for systemic non-biological therapy. Offer to people with psoriasis if it cannot be controlled with topical therapy, it significantly impacts physical, psychological, or social well-being. At least one of the following applies: extensive psoriasis, e.g., greater than 10% body surface area or PASI greater than 10. Localized psoriasis with significant functional impairment or distress, e.g., severe nail disease, high-impact site involvement. Phototherapy has been Ineffective, unavailable, or resulted in rapid relapse, defined as greater than 50% of baseline severity within 3 months. Choice of drugs, first choice agent, methotrexate for people meeting criteria for systemic therapy. In cases with active psoriatic arthritis, consider consultation with a rheumatologist to choose an appropriate systemic agent, cyclosporin. First choice for rapid or short-term disease control, e.g., flare-ups is palmoplantar pustulosis. Those considering conception, men and women, where systemic therapy is necessary, switching treatments. Consider switching between methotrexate and cyclosporin when the first choice treatment does not provide adequate response, acitretin consideration. For adults with psoriasis, consider if methotrexate and cyclosporin are not appropriate or have failed. For pustular forms of psoriasis, exceptional cases for children and young people. Drug regimens, methotrexate, start with 5 mg to 10 mg once a week, gradually increasing up to a maximum of 25 mg a week. Assess treatment response after 3 months at the target dose. Stop if response is inadequate, example, less than 75% decrease in PASI score or less than 50% decrease in PASI score and less than 5 points in DLQI score. Use the lowest possible dose to maintain remission. Cyclosporin, start with 2.5 to 3 mg per kilogram per day, escalating to 5 mg per kilogram per day after 4 weeks if no response or rapid control is needed. Assess treatment response after 3 months at the optimum dose. Stop if response is inadequate, example, less than 75% decrease in PASI score or less than 50% decrease in PASI score and less than 5 points in DLQI score. Use the lowest possible dose to maintain remission for up to 1 year. Do not use continuously for more than 1 year unless disease is severe or unstable. Acitretin, start with incremental dosing to minimize side effects, targeting 25 mg daily in adults. Consider escalating to 50 mg daily if no other options are available. Assess response after 4 months at the optimum dose. Stop if response is inadequate. In plaque-type psoriasis, less than 75% decrease in PASI score or less than 50% decrease in PASI score and less than 5 points in DLQI score. In pustular psoriasis, not achieving clear or nearly clear on the static physician's global assessment. Methotrexate and risk of hepatotoxicity. Methotrexate and hepatotoxicity risk. Methotrexate can cause a significant rise in transaminases. Long-term therapy may be linked to liver fibrosis. Monitoring for hepatotoxicity. Before and during treatment, evaluate the risk of hepatotoxicity in individuals with psoriasis. Use standard liver function tests and serial serum procollagen 3 levels for monitoring. Consider pre-existing risk factors like obesity, diabetes, and alcohol use. Track baseline results and trends over time. Serum procollagen 3 levels, not suitable for children and young people, may be unreliable in people with psoriatic arthritis. Positive predictive value, 23% to 95%. Negative predictive value, 89% to 100%. Provide advice on modifiable risk factors. Offer guidance on alcohol intake and weight reduction where appropriate. Specialist referral. Seek specialist advice or refer to a clinician with liver disease expertise if liver test results are abnormal. Systemic biological therapy. Biological agents for psoriasis should only be initiated and supervised by specialist physicians experienced in treating psoriasis, and psoriatic arthritis. Consider both psoriasis and psoriatic arthritis when starting or adjusting biological therapy. Manage treatment in consultation with a rheumatologist. Adalimumab in adults. Adalimumab for plaque psoriasis, recommended for adults with severe plaque psoriasis, PASI greater than or equal to 10 and DLQI greater than 10, when psoriasis has not responded to standard systemic therapies, cyclosporin, methotrexate, PUVA, or the person is intolerant or has contraindications. Discontinuation criteria. Discontinue if no adequate response by 16 weeks. Defined as a 75% reduction in PASI, PASI 75, or a 50% reduction in PASI and a 5-point reduction in DLQI, using DLQI, ensure DLQI results accurately reflect the severity of psoriasis. Considering disabilities or communication issues. Adalimumab overview, a recombinant human monoclonal antibody that blocks TNF-alpha, reducing inflammation in psoriasis. Initial dose, 80 mg subcutaneously, followed by 40 mg every other week starting 1 week after the first dose, available as pre-filled syringe or auto-injection pen. Common side effects, injection site reactions, infections, dizziness, headache, abdominal pain, stomatitis, nausea, increased hepatic enzymes, musculoskeletal pain, fatigue. Contraindications, active tuberculosis, severe infections, sepsis, opportunistic infections, and moderate to severe heart failure. Cost, £357.50 per 40 mg. Pre-filled syringe or auto-injection pen, excluding VAT. Average annual cost, £10,010 in the first year, £9,295 in subsequent years. Costs may vary with discounts. Etanercept in adults, EMA withdrawal of ifilizumab. The European Medicines Agency, EMA, has withdrawn the marketing authorization for ifilizumab, Raptiva, a psoriasis drug by Merck Serono. Safety concerns. The decision followed concerns about the drug's association with progressive multifocal leukoencephalopathy, PML, a rare but fatal brain infection. The EMA's Committee for Medicinal Products for Human Use concluded that the risks of ifilizumab outweigh its benefits. National Formulary. Update: ifilizumab should not be prescribed to new patients. Patients already on ifilizumab should have their treatment reviewed. Infliximab in adults. Infliximab as a treatment for plaque psoriasis, recommended for severe plaque psoriasis, PASI of 20+ and DLQI of 18+. Must have failed to respond to standard systemic therapies, e.g., cyclosporin, methotrexate, Puva, or be intolerant to them. Criteria for continuing infliximab: continue treatment beyond 10 weeks only if the psoriasis shows adequate response. 75% reduction in PASI score, PASI 75, or 50% reduction in PASI score, PASI 50. Plus 5-point reduction in DLQI. Infliximab, Remicade, overview, indicated for moderate to severe plaque psoriasis in adults, administered via intravenous infusion, 5 mg per kilogram, at 0 to 6 weeks, then every 8 weeks. Costs approximately £11,750 annually, may vary due to procurement discounts. Adverse events, common, infusion-related reactions, infections, delayed hypersensitivity. Contraindicated in moderate to severe heart failure and active infections. Screen for tuberculosis before starting treatment. Ixekizumab in adults. Ixekizumab for plaque psoriasis, recommended for adults with severe plaque psoriasis, PASI of 10+ and DLQI of 10+. Must have failed to respond to or be intolerant of standard systemic therapies, example, cyclosporin, methotrexate, Puva, or have contraindications to these treatments. The patient access scheme provides a discount on the drug price. Treatment response: stop treatment at 12 weeks if there is no adequate response. Adequate response: 75% reduction in PASI, PASI 75, or 50% reduction in PASI, PASI 50, plus 5-point reduction in DLQI. Adjustments for PASI and DLQI. Consider skin color when assessing PASI score and make necessary clinical adjustments. Consider disabilities or communication difficulties when assessing DLQI and make necessary adjustments. Ixekizumab. Taltz inhibits IL-17A, a pro-inflammatory cytokine. Indicated for moderate to severe plaque psoriasis in adults who are candidates for systemic therapy. Common adverse reactions: upper respiratory infections and injection site reactions. Dosing: 160 mg at week 0, then 80 mg every 2 weeks until week 12, after week 12 80 mg every 4 weeks. Clinical considerations. Treatment started before this guidance can continue without changes to funding arrangements until the clinician deems appropriate to stop. Secukinumab in adults. Secukinumab for plaque psoriasis, recommended for adults with severe plaque psoriasis, PASI more or equal 10 and DLQI more than 10. Must have failed standard systemic therapies, example cyclosporin, methotrexate, PUVA, or have contraindications or be intolerant to them. The patient access scheme provides a discount on the list price. Treatment response. Stop treatment at 12 weeks if no adequate response. Adequate response. 75% reduction in PASI 75, or 50%. Reduction in PASI 50, plus 5-point reduction in DLQI. Secukinumab, Cosentyx, mechanism of action, monoclonal antibody that neutralizes interleukin-17A, involved in autoimmune responses in diseases like psoriasis. Indicated for moderate to severe plaque psoriasis in adults eligible for systemic therapy. Common adverse reactions: upper respiratory tract infections, oral herpes simplex, rhinitis, diarrhea, and urticaria. Dosing. 300 mg subcutaneously at weeks 0, 1, 2, and 3, followed by monthly maintenance from week 4. Clinical considerations. Treatment initiated before this guidance can continue without changes to funding arrangements until deemed appropriate by the clinician to stop. Ustekinumab in adults. Ustekinumab for plaque psoriasis, recommended for adults with severe plaque psoriasis, PASI more or equal than 10, DLQI more than 10. For patients whose psoriasis has failed to respond to standard therapies, example cyclosporin, methotrexate, PUVA, or who are intolerant to or have a contraindication for these treatments. Treatment response. Stop treatment if no adequate response after 16 weeks. Adequate response. 75% reduction in PASI 75, or 50% reduction in PASI 50, plus 5-point reduction in DLQI. Ustekinumab, Stelara, mechanism of action, monoclonal antibody targeting IL-12 and IL-23, blocking the inflammatory cascade involved in psoriasis. Indicated for moderate to severe plaque psoriasis in adults who have failed other systemic therapies. Dosing: 45 mg for less or equal to 100 kg, or 90 mg for more than 100 kg. Administered subcutaneously at week 0, week 4, then every 12 weeks. Adverse events: common upper respiratory tract infections, nasopharyngitis, depression, headache, dizziness, diarrhea, pruritus, back pain, fatigue. Injection site erythema. Contraindications: active infection and hypersensitivity to the drug or its components. Adalimumab, etanercept and ustekinumab in children and young people. Adalimumab, Humira, recommended for children and young people aged 4 years or older, severe plaque psoriasis, PASI more or equal to 10, that has not responded to standard systemic therapies, example, cyclosporin, methotrexate, phototherapy, or when these treatments are contraindicated or not tolerated. Treatment duration. Stop after 16 weeks if no adequate response, defined as 75% reduction in PASI. Dosing: subcutaneous. 0.8 mg per kilogram weekly for 2 doses, then every 2 weeks. Marketing authorization: severe chronic plaque psoriasis in children from 4 years who have inadequate response to topical therapies and phototherapies. Etanercept, Enbrel, recommended for children and young people aged 6 years or older, severe plaque psoriasis, PASI more or equal to 10, that has not responded to standard systemic therapies or when these are contraindicated or not tolerated. Treatment duration. Stop after 12 weeks if no adequate response, defined as 75% reduction in PASI. Dosing: subcutaneous 0.8 mg per kilogram weekly up to a maximum of 50 mg for up to 24 weeks. Marketing authorization: chronic severe plaque psoriasis in children and adolescents from 6 years with inadequate response to systemic therapies or phototherapies. Ustekinumab, Stelara, recommended for children and young people aged 12 years or older, severe plaque psoriasis, PASI more or equal to 10, that has not responded to standard systemic therapies or when these are contraindicated or not tolerated. Treatment duration. Stop after 16 weeks if no adequate response, defined as 75% reduction in PASI. Dosing: subcutaneous 0.75 mg per kilogram for less than 60 kg, 45 mg, 60 to 100 kg, or 90 mg, more than 100 kg, at weeks 0 and 4, then every 12 weeks. Marketing authorization: moderate to severe plaque psoriasis in adolescents, 12 years and older, with inadequate response to systemic therapies or phototherapies. General recommendations. Treatment choice should be individualized based on discussions with the clinician, patient, or carers. If biosimilars are available, start with the least expensive option, considering administration costs and required doses. Adjust PASI assessment for skin color, and make adjustments for disabilities or communication issues when using DLQI. Changing to an alternative biological drug. Consider switching to an alternative biological drug in adults if the psoriasis does not respond adequately to the first biological drug. Primary failure, as defined by 10 weeks for infliximab, 12 weeks for etanercept, ixekizumab, and secukinumab, 16 weeks for adalimumab and ustekinumab. The psoriasis initially responds but then loses this response. Secondary failure. The first biological drug cannot be tolerated or becomes contraindicated. For inadequate response to a second biological drug, seek advice from a super specialist clinician with expertise in biological therapy.